So Harvey suggested that I should have worn a wizard hat to the talk, and that would have made it more fun, but I didn't think of that. So this is what's happened at Peter Mac. PSMA has really come along very quickly and replaced fluoride PET and fluorocholine PET. And Rod Hicks spent a lot of time building up this fluorocholine PET program with a lot of effort. And we weren't expecting PSMA to come along, but it really did. And now we almost do no fluorocholine and very little fluoride PET, with PSMA rapidly replacing it. So it's clear that this has come along as a disruptive technology. No one really foresaw this coming, but it was evident from really the very first case. This is the first gallium PSMA 11 PET that we did in our centre back in 2014, and we can see very high uptake in the prostate primary, a sub-centimetre node and a bony metastasis, so complete staging. And there was a flurry of referrals, and it quickly became evident that we were struggling with the increased sensitivity. We were seeing lesions that were really very tiny, but we knew it was still only the tip of the iceberg, and we foresaw this up front, and we would actually tell our radiation oncology colleagues and our surgical oncology colleagues, this is microscopic disease. Just because you see it doesn't mean you need to treat it. We believe that it's real, but perhaps you should just watch it and do nothing, since this disease is very small in volume. And we had a lot of experience with other tumours, as you do as a PET physician, and also our experience with dotatate in the neuroendocrine tumours, to know that perhaps this small volume disease was very low risk and we shouldn't be doing anything about it. But our referrers didn't necessarily listen to us. So we did see a lot of those PokeMet cases where clinicians went almost like a war, attacking all these hotspots, excising them, giving them radiotherapy. This is one such case. This is a patient who has a chain of retroperitoneal nodes. Now, this was not visible on conventional imaging, CT scan or bone scanning, or perhaps not even on MR. So in that setting of slowly rising PSA, you would have two options conventionally, to do nothing or to commence hormonal therapy. But once you can see it, you add perhaps three more options: surgery, radiotherapy, or if you were really aggressive, chemotherapy. And this patient chose to have surgery, a pelvic and retroperitoneal nodal dissection. And the surgeon called me up after the procedure and said, "You described 8 nodal metastases on your PSMA PET. Well, I found 24 at surgery." And I was a bit like, why would you operate on a patient that's got such extensive nodal disease? It's very unlikely that you're ever going to cure this patient. We know we're just seeing the tip of the iceberg. It's not surprising that you can find some other lymph nodes with 1 or 2 millimetre deposits in it. And when the patient came for restaging only 3 months later, indeed now we could see supraclavicular nodes and a bony metastasis. So biochemical response was shortly followed by progression. And to me, it's quite clear that this patient did not benefit from the surgical procedure. But more importantly, they didn't benefit from the PET scan, because the PET scan kind of directly led to that. So I think we need to be mindful as PET physicians that we educate our referrers in how to use the results of these tests, because otherwise we become part of the problem. We facilitate perhaps inappropriate interventions that can follow. And another example of an oligometastasis seen in the pelvis, a 4 millimetre node. This was treated with stereotactic radiotherapy, and 6 months later there is upstream failure in lymph nodes, perhaps not surprising. And if the recurrence occurs very close by, they can be more difficult to treat. So there's been a whole rapid growth of retrospective heterogeneous data from a variety of centres around the world, and there's very little prospective data on PSMA PET. This is one of the few prospective studies from Louise Emmett in Sydney, looking at a select subgroup of patients that had PSA between 0.05 and 1 that was scheduled conventionally to undergo blind radiotherapy to the prostate bed. And she showed and presented the data this morning, a 29% high management impact. And this is an area where it makes sense. If you've got disease outside the prostate bed and your plan is just to give radiotherapy to the prostate bed, that's going to be a futile exercise. It makes sense to modify the patient's management accordingly. So another area where I think we can have a high impact is in high-risk disease. This is a patient with Gleason 9 prostate cancer who had conventional imaging, at the time consisting of a CT, bone scan and MRI. But PSA only fell from 9 preoperatively to after a radical prostatectomy to 7. And at that time point, the patient underwent a PSMA PET, and we found widespread bony metastases, which was not evident on conventional imaging. And I think it's probably true that this patient did not benefit from a radical prostatectomy. And if they'd had the PSMA PET scan up front, perhaps the morbidity of that procedure could have been avoided. So PSMA PET has emerged as a potential new gold standard. It may supersede other imaging as a one-stop shop. It's got potential for widespread clinical availability at low cost, and it produces images of really high target to background contrast. But despite promise, we've got minimal phase 2 or multi-centre data, and much of the literature was focused on biochemical recurrence, but that has changed. There's been a rise in literature looking at staging this year. And so we put together a phase 3 multi-centre trial to assess the utility of PSMA PET-CT, and this came on the background of our involvement in a randomised controlled trial of fluoride versus MDP, which was run about 5 years ago. This was a multi-centre trial, mainly run out of the US, but also some centres from Europe, and you can see our recruitment in this study. So we work very well with our clinicians in getting patients on trials. And we'd also been running a randomised controlled trial of fluorocholine PET compared to conventional imaging, which was run by Scott Williams and Rod Hicks. And this lay the foundation to design a randomised trial for PSMA. And we put an application into a clinical trials grant from the Prostate Cancer Foundation of Australia via some Movember funding, and they have agreed to fund this project, which we're calling the Pro-PSMA clinical trial. This is a prospective randomised multi-centre study of the impact of gallium-68 PSMA PET for staging high-risk prostate cancer prior to curative intent surgery or radiotherapy. And you can see we have a lot of partners in this trial that has made it possible. It is going to be run at a variety of centres across Australia. All these centres are already doing gallium PSMA PET, so they're already set up to go. And we aim to take patients with high-risk disease, defined by a PSA over 20, Gleason grade group 3 to 5, this is the newer classification, or a clinical stage over T3. They're then randomised 1-to-1 to either a PSMA PET or a CT and a bone scan. And as you've probably heard through this meeting, PSMA PET is already widely available in Australia. In Melbourne there are, I think, 9 centres where you can get a PSMA PET. So it would be difficult for patients to participate in this study if they were just going to get conventional imaging and that was it, because even our urological colleagues, perhaps without strong evidence base, have already moved across to PSMA PET. So we've put a crossover design in this trial, which means if your CT and bone scan was completely normal, you then cross over and you get the PSMA PET CT, or vice versa. But if your first-line imaging shows widespread distant metastatic disease, so your bone scan shows metastases elsewhere, everywhere, then you do not cross over because there's not a lot of benefit. And then we look at our outcomes, which is management impact, which is recorded prospectively, and accuracy. And we have other endpoints of cost comparison with a health economist involved in the trial, radiation exposure. I think we heard on Sunday, for those that heard Richard Wells talk, that there's a growing interest, particularly in the US, about which test or which workup results in the least radiation dose to patient. And I think gallium-68 is very favourable in this setting. Reproducibility, and a subset having whole body MR. So the primary objective is to look at diagnostic accuracy of PSMA PET compared to conventional imaging. And it's a little bit hard to define accuracy, because although we like to biopsy everything, that's not necessarily feasible. So we've adapted this criteria from that fluoride multi-centre study, which was designed for bony metastases, to a newer version. And essentially we've got a rigid score, and you require 1 hard criteria or 3 soft criteria. And this is determined at with 6 months of follow-up to score whether the original study was true or false. So if you've got histopathology demonstrating prostate adenocarcinoma, that's 1 hard criteria, that's taken as unequivocal. But then if you don't have histopathology, you need to have 3 of these soft criteria, which I won't go through. But for example, it's an increase in number or size of bone or soft tissue lesions over time from one scan to the next. That would not be enough. You would need 3 of these soft criteria. And since it's defined rigidly up front, the health technology assessment people and other assessors are very happy that we're not making this up as we go along. We have some secondary objectives, which was to look at first-line management impact, and we debated for quite some time whether this should indeed be the primary endpoint. We're looking at the number of equivocal studies in each arm, since that's a relevant endpoint. The incremental utility in those that cross over and have one of these scans as a second-line test, cost, radiation exposure, subgroup analyses, and also reporter agreement. We have some quality assurance embedded in the study. So we have the Australian Radiopharmaceuticals Trials Network, and they will be validating each site at startup to look at both the PET scanner and gallium generator and radiopharmaceutical aspects of each site to make sure that they meet a minimum standard. And we also have embedded an imaging core laboratory, which is run through Peter McCallum to check the patients randomised to PSMA PET to look at observer variability. This is a 200-patient study with 100 patients in each arm, and there's underlying assumptions that have been made to get to that number. So we hope that this study will be of significance. We believe it's the first randomised controlled study. It's just been through ethics in our institution at Peter Mac, and they've given it the tick, subject to a few amendments that I'll get to work on after this meeting is completed. And one of the good things about doing research in Australia is once this is approved by our ethics committee, we have a national ethics collaborative agreement. So this will automatically then be approved in all the other states where this study is up and running, which saves a lot of time and effort. Each centre doesn't need to do their own ethics submission. I've stolen this slide from Josh Mailman, who did an excellent talk yesterday. And I think the patient talks yesterday were really very inspiring, both Josh's and Paul's talk. And Josh spoke about the valley of the death and how perhaps we'd gone wrong with lutetium dotatate with PRRT by doing it as a study solely on compassionate access and not generating the type of data that regulatory authorities demand to get this available, mainstream and funded. So I added a few annotations to his slide. So I think when you're in this basic research, applied research and your grants, you're fairly happy. When you give it as compassionate access or phase ones, the patients gets access to it. But unless we do phase 2 and phase 3 studies and work out ways to produce and distribute the therapies that we're doing, then a large number of patients are denied access to the therapy, and it becomes a therapy that some people can access in large academic centres, but it's not available to the masses, and people die in this valley of death. I'd make perhaps a comment on Josh's talk that when probably Rod started the lutetium dotatate program at Peter Mac, neuroendocrine tumours there was no centralised systems. These were rare tumours, and it would be very hard to even think about doing a NETA-1 trial 15 years ago, because at best you were treating 1 or 2 patients every few weeks, and the thought that you could get so many hundred patients together for a rare tumour was really perhaps quite a challenging thing at that time point. And only once we saw the amazing outcomes from that therapy did people think about doing larger collaborative trials. But with prostate cancer, it's really a different world. This is a much more common tumour. It's much easier to find patients. So we really do need to be doing high quality prospective research. So when we started doing lutetium PSMA at our centre, we had learnt from the PRRT experience, and we did this as part of a prospective phase 2 well-designed trial. The hypothesis was that lutetium PSMA would result in effective delivery of beta therapeutic irradiation to sites of malignancy with an acceptable safety profile, and that we would observe clinically significant benefits. And it's perhaps worth mentioning that the co-investigator of this trial is John Violet, who's here. He's a radiation oncologist who's done a PhD in radioimmunotherapy, and most of his radiation oncology friends think that he's a little bit crazy venturing into the internal radiotherapy space, but he's perhaps seen the future, and we have some excellent associate investigators, Shaneen Sandhu, our medical oncologist, Professor Rod Hicks, who's really provided the infrastructure over a number of decades to allow us to do these sorts of innovative trials in our centre. Peter Yu, our radiopharmacist, Price Jackson, our physicist doing the dosimetry, and Mark Scalzo as our technologist coordinating all of this. And none of this would have happened without the efforts that had come before it, from DKFZ coming up with the PSMA 617 that we're using and producing some preliminary data, which made it much easier to get this study through our ethics committee, and Richard Baum, who had also done a large number of PSMA 617 therapies, which allowed us to sort of optimise our protocol. The lutetium for this study was provided from ANSTO, which is producing no carrier added product out of the Lucas Heights, and ABX are providing our 617. The inclusion criteria are somewhat similar to the compassionate access German and other European studies that have been come to date. So these are patients that have failed first-line chemotherapy and abiraterone, enzalutamide, or both. They have to have progressive disease either by RECIST or bone scan or new pain in an area of disease. They have to have a PSMA PET scan that's positive with an uptake greater than twice liver. The inclusion criteria are fairly standard, but probably the one we've added is an FDG PET CT. And we don't treat patients that have FDG positive, PSMA negative discordant disease. And this is again something we learnt from our 10-year experience or 20-year experience with PRRT in neuroendocrine tumours, that we can have marked tumour heterogeneity. And if we can't target all sites of disease, our therapy is likely to be ineffective. The primary endpoints were twofold: one, to look at toxicity, and two, to document indicators of efficacy, being quality of life, radiologic response, molecular imaging response, and PSA response. Secondary objectives were dosimetry and progression-free and overall survival. As I've alluded to, we're using the Heidelberg PSMA 617 compound distributed through ABX, and the lutetium comes from ANSTO. The study schema is fairly straightforward. I've put in red perhaps some things that our trial differs from some of the other studies that have come to date. We've integrated FDG. All our patients have completed quality of life questionnaires at serial time points, and we do this via an online automated questionnaire. So the patients are emailed a quality of life questionnaire that they fill in online, and it automatically populates our database. We are just using oral hydration, so that it's given a little bit like radium. The patients come, have an intravenous line put in, and then they go home after their post-therapy imaging is performed. So this is an outpatient therapy in Australia, which is different to the rest of the world. We have an adjusted dose from 4 to 8 gigabecquerels that I'll explain to you on the next slide, and all patients are getting voxel-based lesional dosimetry that I'll also show you. This is the detailed schema. We learnt from our PRRT experience and doing a lot of dosimetry in our centre that the one-size-fits-all is perhaps not the best way, but likewise we want some sort of standardisation so that it is reproducible. So here we have a dose adjusted between 4 and 8 gigabecquerels, and we use this calculator. So if you have more than 20 sites of disease, we add 1 gigabecquerel. If your weight's over 90 kilograms, we add a little bit. If your GFR is normal, we add a little bit, and likewise we subtract. Most of our patients, according to this calculator, have actually been getting between 7 to 8 gigabecquerels for the first cycle. This is a patient that was screened. This is the PSMA PET. You can see some uptake in the femur in that bony metastases and some uptake in the liver. When we did the FDG PET, we saw a much larger burden of disease, with much of the FDG avid disease not lighting up on the PSMA. And when we fuse these images together, we can see that, in fact, quite a large amount of the disease can't be targeted. We could quantify that and see that there's over 2 litres of disease, in fact, that we can't target. So this patient failed screening and did not proceed to have therapy. This is one of the patients on the trial. This is perhaps a typical patient, has failed 6 lines of therapy. This is the PSA over 6 years, and now has rising PSA with increasing fatigue and increasing pain. This is the gallium PSMA PET showing a very extensive bony metastases, but also bilateral adrenal metastases and some pulmonary metastases. Our calculator gave this patient 8 gigabecquerels of lutetium-177 PSMA. After the first dose, patients have imaging at 4 hours, 24 hours and 96 hours. This is done with a 3-bed-step quantitative SPECT CT. We fuse all these images together. We co-register them using the CT, and then we got an automated method to do voxel-based lesional dosimetry. And this is from Price Jackson, our physicist, and what he outputs back to the doctors is actually a single new DICOM file that looks like a PET scan, but with every voxel being in grey delivered to that voxel. So we can just load it up in any PET scan software, and anything in red according to this colour scale received over 50 grey, and so forth. So you can see these, one of the adrenal metastases received 68 grey, bony metastases 38 grey, and you can see the doses below. So I've got a slide just to show how easy this is to do. So we open up our dosimetry file, which is a single image, where every voxel has the area under the curve already calculated and embedded. We then draw a region of interest. Here I'll draw a region of interest over this kidney. And we match the anatomy so that we look at the CT and we can adjust the region of interest. You'll see that, and that looks like a fairly good fit for the kidney. And then we can look at this number here, the mean dose, 3.2 grey. That's the mean dose to that structure in the kidney. So the doctors can actually do the dosimetry after the physicist has outputted this file. So it's really very, very neat. So we do regions of interest over all the organs and get our mean dose to all those tissues. This patient, after the second dose of lutetium PSMA, was having a very rapid response. We can see that here. And we know also from our experience with lutetium dotatate in neuroendocrine tumours that given this rapid response, if we were to give a third dose in this patient, there probably wouldn't be much effect since there's very little target left to treat. So in fact, our protocol enables us to do a gallium PSMA PET scan 4 weeks after the treatment to decide whether to continue on and give a third or a fourth dose. So we see rapid decrease. It's likely that lutetium PSMA cycle 3 will be futile. We repeated the PSMA PET and it was actually showed a complete response. So we stopped at 2 cycles of therapy in this patient. The PSA declined from 970 down to 7. We see a good morphologic response with regression of the adrenal metastases. We can see here that the adrenal metastases were progressing on enzalutamide and then had a complete anatomic regression after lutetium PSMA, and likewise a pulmonary metastasis which progressed on enzalutamide disappeared completely with PSMA therapy. The PSMA came down, and I think most importantly the patient's quality of life improved. The global health score improved, fatigue decreased, and pain went down from 27 to 0. We are using the EORTC QLQ-C30 and the BM22 scores to do this. This patient has been happy for us to use these images, and we don't have a patient advocate session today like we did yesterday, which is a little bit of a shame. We probably should have put that in the program. So I thought I'd include this picture. This patient's wife was an ex-oncology nurse, and she was interviewed for a write-up, and she wrote, before he was on heavy medications to cope with his bone pain, and he spent most of the day asleep. He felt weak and without hope, and afterwards, within a week, he was up and cleaning the garage without painkillers. And as a former oncology nurse, she'd never seen anything work like this before. So I think from an N=1, we know that this is a pretty effective therapy. But this is not a curative therapy, and this patient 10 months later did progress. The PSA started rising back up to 500, not quite as high as the beginning of 2,500, and we have capacity in this protocol to give some maintenance doses down the track as the compassionate access for patients that have participated in the prospective trial. So this patient has received a maintenance dose, which is actually now only the 3rd dose of lutetium PSMA, and you can see that 12 months after commencing the trial, his PSA dropped from 500 to 72 after that 3rd dose, and we await follow-up in this patient. If you are going to see hematotoxicity with this therapy, this is the sort of patient you may expect to see this on. This is almost a PSMA super scan in someone that had failed docetaxel and abiraterone. You can see the images after each of 4 cycles of therapy. The patient had 8.3, 8 gigabecquerels of therapy through each cycle, 7 gigabecquerels for the last cycle, and there was a grade 1 anemia at baseline which persisted but was not worsened. So we really saw no hematotoxicity, and this is the response after therapy. Again, this patient did progress, and we can see that the progression-free survival according to PSA was 272 days, which I think is quite a remarkable result given the extent of disease burden in this patient. So we do have a lot of uncertainties that we'd like to answer. We don't know the optimal number of cycles, the optimal administered activity, the optimal selection of patients. We don't have formal response criteria. It seems intuitive to me that the combination of PSMA and FDG is probably optimal, but we don't have validated systems for that like we do for RESIST or the PCG W2 criteria. But it's clear to me that we need to incorporate maintenance lutetium PSMA for patients who progress with PSMA-avid disease. This is not like progressing on enzalutamide, because if you progress on enzalutamide, you've kind of exhausted that line of therapy and you need to then look at what else can we treat the patients with. When we progress with lutetium PSMA down the track, we have the potential to retreat with further treatment. So this is not really progression in the sense that the treatment is no longer working. But we need to standardise criteria and guidelines for when we should trigger a retreatment. And how many cycles is the maximum is an open question. So this phase 2 trial is coming to an end. We've almost recruited the 30th patient, but it is going to take another perhaps 6 to 9 months to get to the primary endpoint when we analyse the results in this cohort. But the results are encouraging, and now we want to move forward with a phase 2 or 3 randomised controlled trial. And the Australian-New Zealand urologic group in conjunction with the Prostate Cancer Foundation of Australia have a $1.5 million grant to look at a 3-year clinical trial, and they've put this towards a randomised multi-centre trial of lutetium PSMA in Australia. And this trial is currently being designed, and I hope it will look something like the NETA-1 trial for neuroendocrine tumours, but in the prostate cancer space. And you can see from this picture that they've included in the brochure for this. This is from their external beam world, that they've gone out on a bit of a limb to fund lutetium-177 PSMA. This is not, something that the trials groups have gotten into in the past, but they've looked at the preliminary data and seen a lot of hope for this therapy. So we're very grateful for them for funding this trial, and hopefully we'll have some positive results in the years ahead that will enable this therapy to be more widely accepted and more widely funded. Because as I look at the PSMA literature today, both on the diagnostic and particularly on the therapy side of things, the therapy is confined largely to the nuclear medicine literature. And our oncology colleagues, they don't accept retrospective small case series published in nuclear medicine journals. They look at that and they think the data is not acceptable to use, and they always look at the data and pick out the faults. And I've shown some of these incredible responses to senior oncologists, and they look at the pictures and they go, I don't believe this. Maybe you're just attacking the PSMA receptors, and your beautiful response on the scan, you've actually achieved nothing, but you've gotten rid of your target and your scan's improving. So there's a lot of skepticism out there from our medical oncology colleagues, and we really need to convince them with high quality data, otherwise this treatment will not be widely available or accepted. So thank you very much.
Thank you very much, Michael, for this interesting talk. This talk is now open for questions. There's one question here at the front.
Well, it's not maybe a question, it's more common that when you look at the literature on lutetium as compassionate treatment in the end phase of prostate cancer, castrate-resistant rather high, and the objective remission rate is rather high. When you compare the result as the PSA response and tumor size response, the response rate is higher than it is in third-line therapy with so-called life-prolonging established therapies, as to whether you, for instance, give chemotherapy after resistance to abiraterone and docetaxel.
So I think I agree with you, but our medical oncology colleagues do not. And we've experienced this with...
This is not a question, this is pure fact.
This is fact, but we've been through this with PRRT for neuroendocrine tumours. We had spectacular responses in patients that had failed all other forms of therapy, that were near death's door and alive 10 years later. But the medical oncologists would come to us and say, oh, those were a few case examples. You pre-selected, the reason your results are so good is because you selected the good players. They come up with all sorts of reasons to debulk, to say that our data is false. And unless we do it prospective, with rigorous inclusion criteria, our colleagues in medical oncology will not believe the data. They will think we've cherry-picked our patients, and it's been possible to transition for it to be a mainstream therapy.
Well, I mean, if you take your study with 30 patients, in the literature already
Yes.
we have about 400 patients published as to this stage. So, I mean...
I accept what you're saying, but I've shown that slide of the spectacular response to a very senior oncologist who's published New England Journal articles, and he looked at me and he said, you didn't give that patient carbazitaxel. And I think carbazitaxel would have done for that patient as good as your lutetium PSMA. And you shouldn't have even given your therapy because there's survival data showing that carbazitaxel improves survival. So why did you use an unregistered experimental product when I have survival data that carbazitaxel improves survival? So there's a lot of skepticism out there, and I'm quite confident that we'll never see a response like that with carbazitaxel. But our medical oncology colleagues don't necessarily agree.
Well, I'll tell you that this argument... I spoke with Professor Brasso in Copenhagen, who is leading the Copenhagen prostate cancer study group at the National Hospital in Copenhagen. He published a paper as to response rate with third-line therapy in a very nice publication. And then I gave him a phone call and said, well, if you have given lutetium instead of this life-prolonging treatment, the patient would have had a better response. And his reply to me was, you're just wasting my time, Finn. Yeah.
Yeah, yeah.